Thank you everyone for watching. I'm Greg Witcher. This is Dr. Thabet of the Department of Orthopedic Surgery. We're going to talk about a few high-yield pediatric fractures for our Pediatric Didactic Month, and we're going to use his expertise to give us some insight on how to best manage these. Before we get started, Dr. Thabet, could you tell us a little bit about yourself, like your background, training, and so on?
So my name is Dr. Thabet, one of the orthopedic faculty at Texas Tech. I work closely at the UMC and the Children's Hospital. I did my pediatric orthopedic training at Louisiana State University, which is affiliated with New Orleans the Children's Hospital. And I did my adult trauma in University of New Mexico in Albuquerque for adult trauma. So I cover both adult and the children trauma. And on my primary focus to do my practice is, I say 50% and 50%, 50% the children and 50% adults. And you will see me a lot in the pediatric ER, seeing patients, evaluating patients, and also in the OR if somebody interested. Then we're happy to come and to see the surgical procedures. And even when I want to rotate with us also in the clinic, he can see the follow-up and how the treatment, our treatment impacted the patient's and family life.
Perfect. Thank you so much. I think you're the perfect person to give us insight. Then we'll have questions for you about not only the ED management, but as well, how do we disposition these patients? Who can go home? Who needs to be admitted? And then what does their long-term course look like? So here we have a pretty common scenario, and we have a 15-year-old girl who landed on her left leg after jumping from 6 feet. So we can assume that this is a closed injury just to make things simple, but I think the important thing here is that on the AP radiograph we see that there's displacement of the distal fibula, and in children when you have the physis or the growth plate disrupted, you have to have special considerations for what might happen given the risk of growth arrest. So can you talk a little bit about this in this kind of the context of the Salter-Harris classification and how you would ideally manage this fracture?
So this one of the very tricky fractures. It can look in the X-ray benign injury and very minimal displacement. However, it could have a great impact on the patients. Given the patient is 15 years old, and we always evaluate the fracture in the context of the child maturity, because if you're concerning what the gross arrest, most of the kids at the age of 15 years old are skeletally mature, and the risk of gross arrest is less of a concern. Okay. So you will look at two factors. You mentioned one of them. One is the gross arrest, which if this is a kid 9 or 7 or 6 years old, that's a huge concern. Yes. Mm-hmm. And we have a very low threshold order a CT in these injuries, because once the injury or the twisting ankle injury causing or the axial loading or the injury happened to the patients, it can go through the physeal plate and is not obvious on the X-ray.
I see.
So you have, as I mentioned, we have a very low threshold or a CT in these fractures. Mm-hmm. And especially go like a Salter-Harris 2, 3, or 4, the CT is one of your best friend to assess the degree of displacement and to confirm the injury as well. Okay.
So how does that change the management from the emergency department standpoint? If we get the CT and we do see a worse injury than we anticipated, is that necessarily surgical?
Surgical, we have the Salter-Harris classification, as you mentioned. We grade Salter-Harris 1, 2, 3, up to 5. Mm-hmm. We have the Salter-Harris 1 is just to grow through the physeal plate. It does not involve the bone or the metaphysis or the epiphysis, or the fracture injury itself go through the physeal plate itself. Mm-hmm. And there is very, people say half Salter-Harris 1, or it's very minimal injury to the gross plate. The kid has non-displaced fracture on the X-rays, but they have pain and the swelling and tenderness, are not able to walk on that leg. And you get the CT, you get your oblique views, 2 oblique views, internal or external, and do the assessment. It look benign. And these patients need casting, need boots, can boot to need some sort of immobilization, either casting or splinting or a cam boot.
Mm-hmm.
Okay, for maybe 3-4 weeks, and after this will be more comfortable. We go to Salter Harris 2, you see the fracture or the injury or the fracture go through the physeal plate and involve a small piece of the metaphysis here. Salter Harris 1 or 2, usually you would treat them with the non-operative management in the form when if displaced the fracture through Harris 2, just need a closed reduction and conscious sedation. If you're from a standpoint, you need a conscious sedation, you need to check the patient AMBOS status and call the orthopedics because one of us need to come to do the closed reduction under conscious sedation and displanting. Okay, so Salter Harris 3 and 4, we go to the second component of the concern about the injury to the distal tibial fossa, which is the displacement at the articular surface. So it's technically is an interarticular fracture now, and we look for displacement, amount of displacement of the epiphysis because of the loss of the joint incongruity. We look for the number, the magic number is 2 millimeters of displacement. And that's why the CT come into play that we need a CT to measure the displacement, the maximum displacement on the 3 views, the axial and the coronal and the sagittal cuts, and do the measurement of the epiphysis, the amount of displacement. If it's more than 2 millimeters, look for consider the surgical treatment, either a closed reduction, just a percutaneous screw to fix it and to compress or to close the gap, or sometimes the periosteum become entrapped into the fracture site and causing the we have to open and lift the soft tissues from the fracture site and then compress it with some screws. And usually the gross arrest for the younger kids say this is 10 years old or 7 years old and has Salter Harris 3 or 4, and now the risk of the concern for gross arrest is much higher. So the younger the kid, the severity of the injury in terms of Salter Harris 3 or 4, the risk of gross arrest is high. So if the gross arrest happen in the mid portion or the middle portion of the epiphysis, this will cause shortening of the leg. So the leg becomes short. But if the gross arrest happen on the periphery of the epiphysis, this means that the kid grow, the gross will be asymmetrical, causing deformity of the leg and shortening. So it can cause pure shortening or can cause shorten and deformity. So the ankle look into varus or look into valgus or maybe other kind of deformities. Okay. So just to wrap up and then the Salter Harris number 5 was the crushing injury. Maybe in this patient, landed her feet 6 feet, maybe causing some sort of axial compression component to the epiphysis, crushing of the epiphysis or the physeal plate. And then the risk of arrest is also higher, especially in younger kids. Okay. So this 15 years old, the amount of displacement, I won't be a little bit worried about this because of the age of the patient. Almost kids, either girls or boys at that age, skeletally mature, and the amount of affection or effect on the gross is less and less important. Okay. Then another important point from the ER standpoint of view as well, what's called the triplane fracture. Triplane fracture means the distal physis of the tibia has a very specific closure pattern. It doesn't close like over weeks or months. It takes 2 years to the entire epiphysis to close and reach the skeletal maturity. So if any injury happened within this 2 years, within the window of 2 years of closure of the epiphysis or the physeal plate, the transition fracture happened, which means part of the epiphysis is closed, part of it is still open. So when you have a twisting injury, always forces go to the line of least resistance. So they will go through the epiphysis, the unclosed portion of the epiphysis, and avoid the stronger part with the closed part of the epiphysis, which technically is a bone right now. You understand this point? And causing the specific fracture at that age was called the triplane fracture. Triplane fracture. And that's a specific fracture pattern that happened in the kids around the skeletal maturity when part of the physeal plate is open and part is closed.
And that for boys and girls is different?
Yes, because
Mm-hmm.
we look for two things.
Mm-hmm.
We have the patient chronological age. You mentioned patient chronological age was 15, right?
Mm-hmm.
But the bone age is the bone age would matter with the maturity of the kid. Say
Right.
if the
Okay.
kid is 15, but his bone age 16, he's 1
Right.
year ahead.
Mm-hmm.
The same you look for Tanner classification for the pubic hair, breast budding,
Mm-hmm.
and
Mm-hmm.
the size of the testicles and stuff like that, and menses. You have to look. So some kids reach skeletal maturity very early on, like 12, and they mature, especially in girls.
I see. So it's a variable thing. So,
Variable, yes, depending on the
yeah,
puberty, what time
right.
of the puberty.
That's very interesting. So for these kind of injuries, depending on the age, we should have a low threshold for CT.
CT, yes,
We should be thinking about the Salter-Harris classification, especially
yes,
if we see a lot of displacement, we might have to intervene surgically.
surgical,
And
yes,
then in certain cases, you could deal with something called a triplane fracture, in
yes,
which the growth plate is affected because it's both open and closed because of the injury, and it will probably lead to a deformity, I presume, down
yes,
the road. Yeah.
yes.
Okay.
And as I told you, you have to be very careful in saying the kid, your ankle is good, you have just to sprain your ligaments, you're fine,
Mm-hmm.
go
Mm-hmm.
home. No, just be careful because once you see in the x-ray, the physeal plate is open or the physis is open,
Mm-hmm.
most likely because the ligaments in kids are stronger than the physis.
Right.
If you
They
have
have
a twisting
relative
injury,
strength. Yeah.
relative strength, you most likely have physeal injury rather than ankle sprain.
Mm-hmm.
So it's different from adult patients. Adults have the physis are closed
Mm-hmm.
and the ligaments are weaker than the bone. So usually when you have a twisting ankle injury, you usually injure the ligaments before the bone, before get fractures.
Right. Right. That's the fundamental concept for
Yes,
pediatric
yes,
orthopedics, I
pediatric.
think.
You
Right.
injure the epiphysis first, then you
Mm-hmm.
injure the ligaments, and then the end injure your bone or break your bone.
Okay.
You
So
have to be aware
first
of that.
epiphysis, second ligaments, third
Yes,
bone. So you should,
yes,
can you assume that there's a ligamentous and epiphyseal injury if you
it
see a
could, but
fracture?
it could, yes.
Okay. All right.
Okay,
Let's go to the next slide. That's really interesting. Great insights. So
thank you.
we're again talking about the ankle here, and in a skeletally mature woman, girl who had a twisting injury and now has this fracture. And this is sort of a kind of board review question. We see that there's some discontinuity on the the lateral side
Yeah,
of the tibia. And then if you look at the lateral projection radiograph, you see that there's a fragment that's anteriorly displaced. So from what I know, this is called a Talot fracture. I think
yes.
it's pretty kind of textbook. Is this a rare fracture or common fracture?
It's common, can happen in
Mm-hmm.
children, and
Mm-hmm.
the more busy your children's hospital is, the more you will match your work at different place in the ER. The more busy
Mm-hmm.
the ER, the more chances to get these kind of fractures.
Mm-hmm.
And that's the anterolateral part of the distal tibial articular surface, and the same thing, the same concept. I get a CT
Okay.
and order a CT to measure the displacement,
Mm-hmm.
and most likely this fracture need fixation,
Okay.
either open or
Okay.
closed. Most likely we have to open and reduce it and put a screw across it, because this is one of the attachment to the anterior tibiofibular ligaments, or the attachment for the syndesmotic ligaments for
I see. I see.
the ankle joint.
Okay. All right. Well, that's some good review of the anatomy there. Let's switch gears and let's look at another common area of injury in kids. And we're talking about supracondylar fractures here. Now, this is not a specific case, just some radiographs from Radiopedia. But what is notable is that on the lateral projection, we see a posterior fat pad, which in my mind is always a pathological finding. However, I would say that the anterior humeral line and the radiocapitellar line look pretty unremarkable here. So I believe from my orthopedics rotation, I learned this should be classified under the Gartland system, and it would be a Gartland 1 fracture. And this is a patient that I, as an emergency physician, would think could probably go home with a posterior slab splint and follow up in clinic. Is that all correct?
Yes, I agree with this 100%.
Okay.
So the posterior fat pad sign is one of the radiographic markers for occult or non-displaced type 1 supracondylar fractures. And before, I mean, that's the most important thing you can see. However, I like the idea that you check the radiocapitellar line. That's very important. I don't like to miss any Monteggia fracture dislocation, especially in kids.
Okay.
And also the other thing that can be easily missed, which is the medial epicondyle of the humerus.
Okay.
So medial epicondyle, which is on the medial side of the elbow, around the start to ossify or to appear on the elbow around the age of the first grade. 5 to 6 years old, you have to look for the medial epicondyle. If you couldn't see it, most likely inside the joint. It's fractured and displaced and entrapped into the elbow joint.
Okay.
So look for the radiocapitellar joint, especially with patients. Some patients with the Monteggia, non-displaced Monteggia, they have only plastic deformation. Doesn't have to be very complete, obvious displaced fracture. Okay.
Okay.
So look for the radiocapitellar line. Make sure the radial head is aligned with the capitellum, and then look for the medial epicondyle. And the other thing that other injury that also can be missed is the lateral condyle fractures.
Right. So hold that thought. We're going to go to the next slide.
Oh, next slide. Okay.
So you kind of transitioned into that perfectly. So I'm going to move this. So what we're looking at here is a 8-year-old boy who fell off his bike onto his elbow. And you're getting into the CRITO, I think, system for classifying the time ossification centers appear. So here, I think what I'm seeing is if it's an 8-year-old boy, the lateral epicondyle has this, what appears to be a fragment, and there should not be an ossification center in an 8-year-old boy at the lateral epicondyle. It's too early. Is that correct?
Yes, and then you have to look for the fracture lines. And this one of the fracture that we emphasize are that 2 views of the elbow are not enough. We need to get oblique views, internal and external. So at least the 3 views of the elbow to get the idea about the non-displaced or minimal displaced or less obvious lateral condyle fractures of the humerus. And the same thing, what we see on the X-ray, we can see only the ossific nucleus of the lateral condyle. Okay. However, the cartilage itself is bigger than that. So the X-ray does not necessarily reflect what the reality is. So you have to, if the fracture line went through the cartilage, this means that the fracture will not be as obvious on the X-ray. That's why we need to see oblique views. And also on my end, if have a doubt, so have 2 options, either order MRI to check the lateral condyle fractures, or I took the patient back to the OR, inject a dye into the joint, I do arthrogram of the elbow, so I can visualize more of the distal humerus. I can see the amount of displacement and the true displacement of the lateral condyle of the humerus. That's the way we manage it, because we have the 2 classifications system. One is called Milch classifications, MILCH, type 1 and type 2. And then we have Jacob classifications, which measure the amount of displacement of the lateral condyle. So Jacob means less than 5 millimeter of displacement. That's Jacob 1, and then between 5 and 10, 2. And then if the lateral condyle is completely displaced and rotated with the articular, with the fracture line displaced, with the articular surface of the distal humerus displaced into the fracture site.
So can you talk about would this cause a lot of morbidity should this be missed, the fracture?
Definitely, this one of the you can't miss this fracture.
Okay.
Because if
what are the consequences of that?
Consequences is very very known in orthopedics, one of the classic orthopedic conditions. And especially in Jacob type 3, when the fracture the articular surface itself rotate and displace into the fracture site. So this means that the patient will develop non-union of the lateral condyle, and this causing a cubitus valgus deformity of the distal humerus. And the cubitus valgus, as the kid grow, this will stretch the the ulnar nerve, the medial epicondyle, on the medial side of the elbow, and called delayed ulnar or tardy ulnar palsy, or delayed presentation of the ulnar nerve. So the patient had numbness and tingling of the pinky and fourth finger with typical deformity of the fingers of the fifth and fourth fingers of the hand.
I see. Yeah, I've heard this is a commonly missed fracture, and it's good to hear what the consequences would be. That valgus deformity and stretching.
Cubitus valgus, yes.
Cubitus valgus, and
or
stretching of the ulnar nerve.
Ulnar nerve. Increase the carrying angle of the distal humerus. Carrying angle increase, that's called cubitus valgus deformity.
The carrying angle. Okay.
Yes.
Okay.
And the opposite happened in supracondylar fracture. Patient with malunion of the supracondylar fractures. If say the fracture displaced, we didn't treat the fracture, or we treated the fracture and then secondary the fracture displacement, even after operative fracture fixation, the patient developed cubitus varus deformity, which is the opposite of the cubitus valgus deformity.
Okay. So these are kind of common pediatric fractures, and they have opposite consequences. It helps remember it a little more easily.
Yes.
So let's take a step back though and talk about the CRITO system for identifying these ossification centers. Is that how you learn these? That's sort of like basic knowledge for you at this point.
Yes. Yeah. I encourage you to develop your mnemonics, but one of the common mnemonic we use for remembering the ossific centers of the distal humerus and the elbow. Okay. Because I told you, say at the first grade, 5 to 6 years old, you have to look for the medial epicondyle and you have to see it. If you see, you can see in this X-ray, you can see the medial epicondyle very obvious.
Okay.
Yeah, because this is 8 years old. But if you couldn't see it, that means the patient has a fracture of the medial epicondyle, and usually it's trapped into the joint.
Okay. So for our listeners, the CRITOE is CRITOE, and that's starting with the ossification center at the capitellum. Then we have the radial head. Then we have the medial epicondyle. The trochlea is the T, the O being the olecranon, and the E being the lateral epicondyle.
Yes, I'm just, I need to touch a little bit on the Milch classification of lateral condyle.
Okay.
With the fracture line, does not involve the trochlea of the distal humerus, this Milch type 1, but if the fracture line extending to the trochlea of the distal humerus, the elbow will be completely unstable. The elbow is dislocated like intra-articular fracture. And this was one of the morbidity factors, or the morbidity risk or problem with the lateral condyle fracture. The elbow can completely dislocated because of this fracture.
I see.
Okay. So you go systematic read of the X-ray. You look at the fat bad sign, front and back. Look for the medial epicondyle. Look for the lateral condyles. Check the radial head for fractures, for dislocation, radiocapitellar lines, and then look for the olecranon, and then look for the fracture line above the olecranon fossa, which is supracondylar fractures. Most typically. And kids, around 1 or 2 years, the young kids, first years of life, the transphyseal separation, this is one of the pathognomonic factor or fractures for child abuse as well. Transphyseal fractures.
Transphyseal fracture in the first years of life.
So
that's a good review, that system for reviewing an elbow X-ray, since we're going to look at so many of these as emergency physicians. We look for the anterior fat pad, the posterior fat pad, the anterior humeral line, the radiocapitellar line. We look for displacement of the radial head, and then transphyseal fracture you mentioned in the end.
Yes.
Perfect. All right, let's go to the next one. So this is a little more of a discussion. I just want to pick your brain about open fractures, and I want to talk about mild open fractures, like a poke hole open fracture like we're seeing in this image here. Is there any instance where you think it would be appropriate for a patient to be sent home for follow-up in clinic with a poke hole fracture due to, say, just like this example, maybe a forearm, a both bone forearm fracture, or is that a necessary admission for operative management?
I said depend on the fracture. Say this is 10 years old, has a radial ulnar fracture, need operative management. We most of the time kids older than 8 years old with the radial ulnar shaft fracture. Yeah, this need to be admitted and need to be IV antibiotics for the open fracture and for the post-operative management after. But my point is poke holes that we can see on the ED does not reflect the amount of damage. We just the grade 1 or still type 1 reflect the skin injury, does not reflect the amount of damage to the muscles, to the bone. So we should be very careful about sending this patient home. But if the patient say, and the contamination as well, if the patient in the playground, bad area, unclean area, I mean, need to be careful about, have to talk to the patient in details, get the story and look for the contamination as well. However, say if the fracture, say some literature saying the patient non-displaced fracture, poke holes fracture or minimal displaced, or a fracture need a closure reduction with poke hole fracture. Some people, you can get the conscious sedation, get the ortho involved, get the fracture reduced, and then you can send patient home with PO antibiotics safely. But you have to see the patient in the first available clinic to make sure the wound is not infected, the patient didn't develop osteomyelitis. But this is a fracture, operative fracture, say for whatever reason, shaft, disc, or humerus, physeal injury need to be addressed operatively. Yeah, we usually extend the incision, make it bigger, look for the damage more, the more damage to the soft tissues, and then address wash it with a generous amount of saline solution and wash it very good, and then deal with the fracture with operative management as appropriate, and then close the wound and splint the patient as needed.
Okay, so just to recap, the damage that you see just from the exterior may not reveal how much damage was done to the soft tissue, and that's one indication that this patient needs to go to the OR. There are rare cases when patients can be sent home for immediate follow-up, but they should be seen by an orthopedist before ever doing something like that.
Yes, I agree 100%.
Perfect. All right. So here we have a both bone fracture. I want to just specifically ask you, I've heard community physicians saying they can sometimes struggle with reductions of these both bone forearm fractures. Do you have any general tips for reducing these in an emergency department setting rather than the OR?
So this injury, it doesn't have to be reduced right away. And the key point that they get look at the age of the patients, amount of each age of patient has acceptable or amount of displacement, tolerated displacement. So we have to put all factors together, and these injuries have to emphasize the fact of remodeling. Remodeling means that there is certain amount of deformities can be tolerated, can be accepted, and as the kids grow, the bone corrects the alignment as the kids grow. Okay. You think it doesn't remodel if the kids are older, so have less than 2 years of growth remaining. The remodeling is very, very minimal. You have to have at least 2 years of growth remaining. Okay. Number two, you have to closer to the most active growth plate to the extremity. Say, for example, for the knee, the distal femur epiphysis and proximal TV are the most active epiphysis in the lower extremity. So the closer to the knee, to the femur, the distal femur physis, and the closer to the proximal tibial physis, the chance of remodeling is very high. The elbow is the upper extremity is is different because most of the upper extremity grow from the proximal humerus physis and grow from the distal radial physis. So if the fracture closer to the rest, the remodeling is high as well. So we can accept more. If the fracture proximal to the proximal humerus or the upper end of the humerus, that means the acceptance, the amount of deformity we accept a little bit higher. Okay.
Okay. Okay.
For the elbow, it doesn't grow much. So the elbow only grow 20% of the height of the length of the upper extremity, only 20%.
Okay.
That's why we treat most of the elbow injuries with operative management.
Mm-hmm.
We are very aggressive treatment elbow fractures with surgery because the remodeling is very, very, very minimal. Okay.
I see. I see.
So once we decide, we look at the X-ray, measure the angulation in both views, AP, a lateral view. By the way, this lateral view is oblique view. It does not give you the reflection of the true displacement. I will send this patient back to the ED, to the X-ray, say I need a good lateral view of the forearm because this is not acceptable, okay?
Okay.
And I'm glad that you mentioned this X-ray, or you presented the X-ray, because this forearm fracture is one of the injuries that emphasize the importance of you have to get one joint above and one joint below the fracture.
Okay.
You can't get just a sketchy or a very small view or group the picture just to see the fracture, ignoring the elbow, ignoring the rest.
Mm-hmm.
For two reasons. One is Montegia fracture dislocation. You have a fracture ulna, but if you don't have X-ray of the elbow, dedicated film of the X-ray or focus or X-ray of the elbow, you won't see the radial head dislocation, right?
Mm-hmm. Mm-hmm.
And the other thing is Galeazzi fracture dislocation. We have isolated radius fracture with dislocation of the distal or the inferior radio-ulnar joints. You won't be able to see it unless you get X-rays of the rest.
Okay.
Okay.
So these X-rays here we're looking at are adequate though, because you can visualize, but they are missing a lateral view. And then, as you said,
yes,
for your elbow fractures, you like to see a third view, the oblique view.
Yes, oblique view. So this assessment looks good. I just send the patient back to get more true lateral of the forearm to get accurate measurement of the amount of displacement. Say this fracture need reduction, and now we have to. Can we do this without pain medication or without, conscious sedation? No, we need to get the patient. Not. We need the patient to be comfortable and get the reduction right, and need the fluoroscopy. We have a privilege here in the UMC that we have a small fluoroscopy or the mini arm. We can see our reduction immediately on the spot. We can check our reduction right away. But some places doesn't have that. You have to get the reduction, feel it, and then send the patient for X-ray, check it. If you don't like it, take the splint down and redo it, which is time consuming and is not a good technique.
No, but I'm glad you mentioned that, because a lot of us will be in community practice in the future and might not have the luxury of the C-arm and have to think about that being a real possibility if it's the middle of the night and the kid, we just want to get the kid to clinic, or the orthopedist isn't in-house or so on. So that's really good to think about. Okay, great. And
then we decided that we need the control sedation, we need the equipment, we need the cast, we need the splint. And then if you ortho with you, you get involved if possible. Yeah. And then we do the reduction maneuvers. So the patient now is comfortable, get the constant sedation, have the C-arm, have the equipment, and then you do the reduction. So this patient look for the apex of the deformity. So this patient look has an apex pointing toward the radius, apex lateral. So we need to little bit of a traction or you can, some people do the Chinese finger traps and to get the muscle ready for reduction, and then you do the reduction, okay? I usually just do a traction and try to do the opposite or the correction, do the correction in opposite direction of the deformity. So this patient has an apex toward the radius, apex lateral deformity, and has also on lateral views, you can see the apex posterior deformity. So I need to push the distal part of the forearm to the front anteriorly. I need to push the distal part of the forearm more toward the ulna or medially. Okay, and have somebody do that counter traction from the elbow, somebody do the traction from the wrist, and then do the correction in that direction. Okay, and then after we finish, just with the padding, cast padding, and the splint. Because of risk of compartment syndrome, it's safer if you are not, but if you are by yourself, to just do the sugar tongue splint or a long arc splint. Avoid circumferential cast because of the swelling and the reduction and the manipulation of the arm and the injury itself. All these factors may increase the chance of developing acute compartment syndrome. Okay,
Right. That's always a risk. Okay.
always a risk with
Yeah.
injury, reduction, tight cast. The three factors can contribute to the development of acute compartment syndrome.
Mm-hmm. Mm-hmm.
So,
Great. Well, you
and the
make it
trachea
sound
reduction.
easy, but I know it's not always that easy. So,
I just need a few cases to do it.
yeah.
It's just a matter of experience. Need
Yeah.
more. The more you do, the more comfortable you're doing it.
Of course.
And after you do the splinting, you do the molding of the cast. Little bit of a mold in
Mm-hmm.
opposite direction.
Mm-hmm.
It's called the 3-point molding of the cast
Mm-hmm.
to maintain the reduction you achieved by the reduction maneuver. Because if the cast is not well molded, the displacement inside the splint or the cast will be a problem down the road. But we'll take care of this in the clinic.
Right, right, right. Okay, awesome. Good. Another good discussion. Let's go to the next one. So this, I believe, is second to last. So we're moving to the lower extremity now. Again, we have a toddler, a 3-year-old, who jumped off the sofa and presents with this x-ray. So I'll just summarize what I see. I see a pretty obvious spiral fracture of the tibia and no other osseous abnormalities. So this is a pretty common thing. Should this raise suspicion for non-accidental trauma, or is this something we can anticipate being just part of kids playing in a traumatic injury?
No, this is not the classic fractures for non-accidental trauma.
Mm-hmm.
It can happen, and the definition of toddler fracture, tibia fracture, most of the time, or almost most of the time, is that fibula is intact. So the fibula is intact, no fracture fibula. You can see this fracture pattern and non-displaced fracture.
Yeah.
And the kid just stopped walking. He was running, playing, and then all of a sudden, maybe the parent didn't watch the kid stop walking. So this should be red flag for you to get an X-ray. Don't say we're good. This just the kid is doing something funny. Get an X-ray. Review the X-ray because sometimes it's very tricky. You see it one view. It's not very obvious. You see, look at the lateral view, a little bit of a crack, but it's not very obvious as you can see it on the AP view, okay?
Okay.
And you have to combine this with the clinical exam of the kid. He stopped running and stopped walking. That's very, very important.
Right, okay. So in X-ray...
Fibula is intact, non-displaced fracture of the tibia around the age of 2 to 3 years old, around 3 years old, this classic pattern of toddler fracture.
Toddler fracture, right. And these can be very subtle, and I know the one I'm showing here is pretty obvious. But management, this is an outpatient injury as far as I am aware. This should be splinted and seen in clinic as soon as possible.
Yes, and it should be this is the classic management. Just coming back to the non-accidental trauma, I just give a touch base with it very quickly. So the one that need to be suspicious of non-accidental trauma, I'm sure that everyone know that femur fracture, non-walking child. So they have a femur and the kid didn't start walking yet. This is child abuse case. Number 2 is metaphyseal corner fracture. See the distal femur, proximal tibia, metaphyseal corner fractures of the metaphysis. That's
those
one
are
of the criteria.
Bucket handle fractures. Is that what those are? Okay.
Yes, and this is number 2. Number 3, posterior hip rib fracture. Fracture of the ribs in the posterior part. Okay, and then multiple fractures. And the fracture in different stages of healing. See, the tibia is fresh fracture. See, the humerus have a callus formation. Femur has a different stage. So multiple fractures with different stages of healing. Okay.
And that might be something you see on like a skeletal survey.
Skeletal survey. Perfect. So this we need a skeletal survey.
All right. Good.
And this is one of the. But this toddler can happen in normal life, can happen with kids without the risk of non-accidental trauma.
But those others you mentioned are the high yield.
Yes. And come to the exam as well, because this one of the it can endanger your license. You have to be careful, and you have to get the social worker involved and know your hospital policy, because most of the children's hospital, any kid with broken bone, they get the social worker involved to make sure the story makes sense. If the story doesn't make sense, they notify the Child Protective Services.
Good. Okay, thank you. Let's get to the last slide here. This is not unlike a case that I saw in RED. We had a 14-year-old boy who had an ATV accident where he stretched out his leg and it kind of ejected from the ATV, and the X-ray looked like this. So this is a little more grainy than the last radiographs, but I think what the finding is most significant for is that the tibial eminence, in other words, the most superior aspect of the tibial epiphysis looks to be fractured in the AP and the lateral view. And
the importance of this is the attachment of the ACL, the anterior cruciate ligaments.
Right.
And this also as well because of most of the cartilage, sometimes not very obvious on the regular X-ray. You can see a little bit, but you feel the knee, patient has hemarthrosis and get injured in soccer or football players, some sort of sports injuries. And this is the attachment of the ACL ligament. And there is a classifications for this with non-displaced fractures. Type 1, type 2 is a fracture is hinging on the posterior cortex. And then the type 3 is the one that completely displaced tibial eminence, a fracture. And this fracture is at least type 3 need operative fixation with sutures and to get the knee stable, because this is the attachment of the ACL ligament. And this is very important to treat this fracture with surgery, but need a CT.
So what study would be the CT or MRI after?
Advanced imaging. This is one of the injuries need advanced imaging.
Perfect. Good. Well, I don't want to take too much of more of your time. It's been really insightful. So unless you wanted to say anything else, I'm going to stop there because those are the images I wanted to review.
Yeah, I think that's very, very useful. And just be careful with the kids. Any kid that refuses to walk, you have to look for trauma fractures, look for infections, and look for septic arthritis of the hip. And especially you have to be very careful. Any patient was presented with knee pain, really have to spend some time examining the hip. You examine the knee, that's okay. And but you have to look for the hip. Don't forget examine the hip. It could be skiffy, slipped epiphysis, upper femur epiphysis, skiffy. It could be infections, could be proximal femur osteomyelitis. Just spend some time with the kid that has knee pain, examine the hip, examine the whole child, ask for the last 3 weeks or 4 weeks has a upper respiratory tract infection and causing transient synovitis of the hip. Patient is refused to weight bear, fever, ESR, and CRB, the Coker criteria for septic hip. Don't forget, don't forget these kids, and also don't forget the non-accidental trauma. And this one of the fractures or the injuries that can endanger your license and your practice. That's very important to pay attention to this.
Yeah, we'll have a whole nother lecture on that. And like you're getting at, I didn't even get into these non-traumatic conditions like septic arthritis, skiffy, and transient synovitis, and so on, but they're always good to have on the differential.
Of course.
Perfect.
Thank you so much for the time.
Thank you so much for your time. I really appreciate you taking some time out of your busy day. Have a great evening.
You too. Thanks so much.
Working with you. Bye.
Take care. Bye-bye. Bye-bye.